like a 20-year-old woman present with depressive symptoms, right, for the past few months. So after seeing the scenario here, you can easily understand that this is a case of PTSD. But the question is that what I have taught you, can you answer me? PTSD is more common in male or female? Yes, this is much, much more commonly seen among females, right? Among females. And this will be seen especially in the young females. Now, the question is that symptoms should be there for how many days? Symptoms should be there for more than 1 month. Same symptoms like PTSD, less than 1 month will be called as what? Acute stress disorder. Same symptoms like PTSD, less than 48 hours. Then it will be called as what? Less than 48 hours. Then it will be called as acute stress reaction. Yes? Chalo. First question is done. Now, second question. Okay, now second question here now. See, a 46-year-old man with a 25-year history of daily heavy drinking is brought to the emergency department with visual hallucination, agitation, fever, tachycardia, hypertension, following 2 days of diarrhea, mental confusion, financial stress. What is the most appropriate initial management? Now, after seeing this question, when I have mentioned here heavy drinking, no, heavy drinking means what? Related to alcoholism only. Related to alcoholism. And symptoms are there just after 2 days here, right? So here, when I talk about this question here, when I understand the case that this is a case of the alcoholism. So when a person can stop taking alcohol in between, when a person can taking a right? So when what I have taught you that which drug has same action like alcohol, that is benzodiazepine. That is benzodiazepine only, right? So any symptoms related to alcoholism, how to treat here? Benzodiazepine means, first of all, you have to give a tablet. First of all, you have to give a medicine of what? Benzodiazepine, like see here, chlordiazepoxide. Chlordiazepoxide, admit the patient, and after that, you have to monitor all the vitals. Okay? See, alcohol is always an important topic. Next question now. Next question. A 19-year-old student reports frequent purging of food. She appears well nourished and has mildly enlarged parotid glands. Besides routine lab test, which investigation is most appropriate to assess potential complication? First of all, can you answer me here? What is the diagnosis? Yes, we can understand. What is the diagnosis? Yes, we can understand. This is a case of eating disorder. This is a case of eating disorder. So my question to you is that, do you think this is anorexia nervosa or this is bulimia nervosa? Okay. More purging episode. Where do you see more purging episode? More vomiting? Yes, we have learned that we see in bulimia nervosa. Well nourished means weight is normal. In bulimia nervosa, weight can be normal and mildly enlarged parotid glands here. I have explained you parotitis, right? Now the question is that which other investigation is most appropriate to assess potential complications? Yes, no, because of what? Repeated vomiting. Yes, there can be what? Abnormal serum electrolytes. So answer B is a better answer here, right? No, serum electrolytes, sodium, potassium, and all. So that if we can admit the patient, we can manage, yes, no, fluid management and all. Yes. Okay. Next question now. Next question. Like a 23-year-old man present to the emergency room with a new onset paranoia. Reports receiving secret TV messages directing him on missions. He appears guarded and suspicious, but is cooperative and not physically aggressive. What is the first step the psychiatry resident would take here? Can you answer me here now? Rahul? First of all, on the basis of the symptoms, basically what I'm asking you is that if you are on duty, okay, you get this kind of patient, right? So being a junior doctor or being a resident doctor, what should be our first priority here? Means, see, remember here, suddenly what new onset paranoia means a suspicious behavior. He has started reporting what? TV secret messages and all. Yes, no, sudden onset of all these symptoms. Remember here, there can be symptoms like delusion and hallucination even after drug abuse also. Young man is here, young man, right? So what we are going to do here now? Yes, we should be expecting Substance abuse here. We should be expecting what? Substance abuse here. What we should be doing here? First of all, we should be ruling out all other substances. Okay, all other substances. This one point is clear to everyone? Yes, very easy to understand here. No? See, this kind of question where you have to use your common sense only. Where you have to use your common sense only. Right? So better answer is C only. Being a doctor, first of all, we have to rule out which drug he would have taken. Next question. Like a patient reports seeing green ghosts whenever he listens to classical music. Same thing I have taught you multiple times. I asked you to revise multiple times here. No, which type of hallucination does this patient represent here? Right? Stimulus in one modality. This can produce hallucination in second modality. Right now, I have gave you the example. See, I have given you the example also. Here, a patient is saying, "What, doctor, whenever I'm looking at the tube light, I start hearing the voices of God." This is a case of what? Synesthesia, which is also called as reflex hallucination. This much point is clear to everyone. Yes, in which drug abuse you can see this? LSD and cannabis. LSD and cannabis. Next question. Like a 29-year-old man has been demanding sex, sleeping very little. See, taking on multiple new projects, working late, showing high energy, and talking excessively for 8 to 10 days. His wife is concerned, but he denies any problems. Can you answer me here now? Now, on the basis of the symptoms, can you answer me what are the symptoms? Bolo. See here, no? When you can understand that, symptoms are 100% when a person is hyper, when a person is overworking, right? Everything is, right? No? So, like when a person is overactive, when full mania is there, full mania, right? No, full mania. Remember here, this is a case of, yes, mania only. Mania, I have taught you, right? No, I have taught you that whenever there can be full major depression and whenever there will be full maniac episode, where do you see? We see this in bipolar number 1. Bipolar number 1. Remember, I also have taught you that what is bipolar number 2? Where half of mania will be there. Okay, no, remember here 100% this is a case of full mania. Full mania means what? Bipolar number 1. Right? Okay. Next question now. Next question. See, a 29-year-old woman presents to the OPD with persistent sadness, difficulty concentrating for past 6 weeks. She reports trouble falling asleep, decreased appetite, and marked loss of interest in previously enjoyable activities and hedonia. Her husband notes she has been withdrawn, tearful, and expressive, like excessive guilt, worthlessness, hopelessness. She denies recent stresses substance use. Mental status examination reveals psychomotor retardation, right? Attenuated speech. She denies hallucination or delusion, but reports occasional passive thoughts of not wanting to wake up. Now, here, how many symptoms you want to diagnose the case here? How many symptoms here? So, what is the answer here? What is the answer, all of you? What is the answer here? Yes, I'm sure you can easily understand here that when there is no any stressor, when there is no other symptoms, right? And symptoms are 100% like major depression only, no? Major depression. So what is the answer here? So remember here, what is the depression? See, the answer will be here what? Like, see, always keep in mind. See, I have given all the options, option B also, option C also, option D also. Why these options are not? Okay, now. So remember here, this PPT will also be shared. But here, whatever we have learned so far, minimum if there will be 5 symptoms for more than 14 days, we can easily understand that this is a case of major depression. Why not dysthymia? Milder form of major depression for more than 2 years. Bereavement means only sadness. Adjustment means what? Mild anxiety, mild depressive episodes. So here 100% this is a case of major depression. This one part is clear to everyone. Very easy to understand here, right? And minimum 5 or more than 5 symptoms should be there. Next question now. Next question. A 45-year-old man is brought to emergency department by his family. They report he has been increasingly withdrawn, neglectful of his hygiene, and has been expressing beliefs that his neighbors are spying on him and controlling his thoughts, right, through television. For the past 6 months, on mental status examination, his speech is coherent but goal directed towards these beliefs. Can you answer me here now? Wow. See here, what is the answer here? If there will be only delusion, then answer would have been delusional disorder. Okay. Suppose if symptoms will be there for less than 1 month, then you will be calling it brief psychotic disorder. Schizophrenia form disorder means what? Symptoms in between, like symptoms in between 1 to 6 months, then only schizophrenia form. So here, what is the answer here? 100% you can say this is a case of schizophrenia, right? This is a case of schizophrenia. Yes, I have taught you that minimum 2 or more than 2 symptoms in same patient. As per DSM-5, more than 6 months, but as per ICD-11, when symptoms are there for more than 1 month only, then you can diagnose it. Then you can diagnose it. Okay, then you can diagnose it. Okay, easy to understand? Okay, chalo, fine. Next question now. Question number 9 here. Like a 28-year-old woman presents with a 2-year history of persistently low mood, anhedonia, low energy, insomnia, feeling of worthlessness. She denies any history of mania or hypomanic episode. What is the first line of? What is the first line pharmacological treatment for her condition? First of all, can you answer me what is the diagnosis here? See here, the way I have taught you, the way we have learned, the way we have revised everything, we have learned that yes, whenever there will be minimum 5 or more than 5 symptoms, we can easily diagnose that here this is also a case of major depression only. Typical depression only. Typical depression only. Right now? Okay, typical depression only. What is the first line pharmacological? Yes, for major depression, first is always what? SSRI. Right now, SSRI is the first only, no? Simple, no? Benzodiazepine, where do you give benzodiazepine? If there will be alcohol related or anxiety related sleeping problem. Okay, typical antipsychotics, where do we use typical antipsychotic as like or any kind of the antipsychotic first in a case of mania treatment here. Okay, fine. So here, right, lithium is a good stabilizer here. Easily you can say answer is B only, SSRI. Next question now. A 19-year-old college student is evaluated for recurrent episodes of discrete periods of intense fear, like accompanied by palpitations, sweating, and see the trembling and feelings of choking. These episodes occur abruptly and peak within minutes. She reports persistent concern about having more attacks. The most acute and effective pharmacological intervention for aborting a panic attack is, can you answer me now? Right, a panic attack. Basically, we can easily understand here that this is a case of, we can easily understand here that this is a case of, okay, this is a case of the panic attack. Okay, panic attack. My question is that when we talk about the panic attack, yes, are you able to recall that which drug I have taught you? Can you answer me which drug I have taught you? See, first of all, whenever there will be the panic attack, we can do behavior therapy. We can do behavior therapy like muscle relaxation technique, deep breathing, and after that, pharmacological treatment. If there is the emergency, always you have to start with the drugs. What should be the combination of drug? SSRI, benzodiazepine, and beta blocker. This is what we have learned here. My question is that when person is having severe panic attack, so like at that time in emergency, what will be the best drug? Can you answer me? Like in emergency, because like SSRI will take more than 10 days, more than 10-14 days. Remember here, benzodiazepine we add here, like this will keep the patient very, very calm. This will keep the patient very, very calm. So first, short acting we can use here. Short acting drug, alprazolam. See, clonazepam is long acting. So out of these four, best is what? First answer will be alprazolam. Okay. Next question now. See a patient A patient consistently avoids social interaction, displays a constricted affect, and report deriving pleasure only from solitary intellectual activities. Okay? He neither desires nor enjoys those relationships. Now, including family ties. During evaluation, he speaks briefly and maintains poor eye contact. Which of the following differentiates his condition most clearly from the avoidant personality disorder? Avoidant personality disorder. Okay. My question is that can you answer me here? What can be? See, what should be the best answer here? Can you answer me? See, what I'm saying here that the question what they're asking, which of the following differentiates his condition most clearly from the avoidant personality disorder? See, in avoidant personality disorder, what we have learned, fear of rejection will be there, inferiority complex will be there. But here, patient speaks less. Okay, most of the time he would like to stay alone. Right now, see, stay alone. So mostly this looks like a schizoid personality. Schizoid personality also. Right now, so where decreased level of sexual activities will also be there, and decreased level of sexual activities will also be there. Family activities will be there. Social activities will be there. And so avoidant personality means fear of rejection, like inferiority complex here. So here, presence of emotional lack of interest, absence. Remember here, I think better answer like here, see, best will be lack of interest in social relationships despite isolation. So mostly I can say here what this is a case of schizoid and not the avoidant. Okay, B is better answer here. No. Next question here, like a 24-year-old male with acute psychosis is started on intramuscular haloperidol. Within 8 hours, he develops painful neck stiffness. Okay, see, torticollis, forced upward deviation of eyeball, and difficulty in swelling. So there can be laryngospasm also. All these are signs of what? All these are the symptoms of what? Acute dystonia only, no? On examination, his vital signs are stable, no fever, altered consciousness. Means this is not actually neuroleptic malignant syndrome. Which of the following statement regarding the management of this condition is most appropriate? So I can easily understand here that this is a case of acute dystonia. This is a case of acute dystonia. So can you answer me here? If there will be dystonia. So can you answer me which drug can be given? Ideally, remember here, ideally we have to give benztropine or promethazine. If these are not available, then we can use a diphenhydramine also. Diphenhydramine with oral anticholinergic drug. I'm sure. See here. So here you would have ruled out all the options here. No? You would have ruled out all the options. This one point is clear to everyone. See, remember here, on the basis of symptoms, I can say this is a case of what? Like extrapyramidal symptom. And extrapyramidal symptom, which can be there due to deficiency of dopamine in nigrostriatal pathway. So if there will be dystonia, how to treat here? Anticholinergic drug or antihistaminic drug. You can easily rule out here. Answer A is correct here. A is the best answer here. Where do we use the propranolol for acute akathisia? Acute akathisia. Where do we use the dantrolene for neuroleptic malignant syndrome or malignant hyperthermia? Next question. See, according to Beck's cognitive theory, depression results from negative views about the self, the environment, and future. Means feeling of hopelessness, helplessness, worthlessness. Okay, this is the assertion. Reason these are negative. These negative cognitive distortions arise due to maladaptive schemas formed from early life experiences that alter the interpretation of both internal and external events. I can say here that assertion and reason both are true here. Okay, no? See here, and this is 100% good explanation, normal explanation also. Okay, so answer A is, yes, answer A is correct. Next question, which of the following statements about kleptomania and pyromania are true? First of all, see, pyromania and kleptomania, these are what? These are the examples of impulsive control disorder. These are the examples of impulsive control disorder. Okay, see, kleptomania is by stealing. Okay, both kleptomania and pyromania commonly show mounting tension before the act and relief or gratification after act. Right? What about the pyromania, fire setting? Okay. Yes, he is suggesting serotonin involvement. Okay, this is also okay, fine. See, kleptomania usually involves planned instrumental theft. No. Both disorders frequently show comorbidity and substance use and mood disorders. My question is that after reading, see here, especially in INI CET, this kind of questions are being framed. So can you answer me what is the answer here? Bolo? What is the answer here? Best answer will be what? Especially in INI CET. I can see here, first of all, see, first of all, option number one, kleptomania is for stealing for the monetary gain, for the monetary. I've explained, why it is not considered as antisocial personality disorder. Because in antisocial personality, no, robbery will be there only for expensive things. Here it is not. Here it is not. So option number one is wrong. Option number two, I can say yes, this can be correct. Option number three, yes, okay, serotonin part, yes, okay, this is also correct. And yes, see here, option number five also. So here, better answer will be D answer. D is more correct. D is more correct here. Next question, in which condition labile indifference? I already have taught you conversion disorder or a dissociative disorder or hysteria. Labile indifference means what? Like see here, indifferent to result. Okay, I gave the example here. After losing one eye, that patient is saying no problem, I'm having one more eye. So it is seen in the conversion disorder. Next question now. In which condition? Okay, this is same thing. I think this got repeated here. No problem. This is the conversion disorder. Next question. See, a boy is experiencing low mood, decreased energy, and decreased interest in his surroundings. He has not been taking food for the past 1 week. The thought sample says, I lost my head. I am dead. How can I eat? Now, you can easily understand here. You can easily understand here that here there will be confusion in nihilistic delusion and bizarre. There will be confusion in these two. Okay, see, this is a case of nihilistic delusion, no problem at all. Okay, no, but I have taught you that when a nihilistic delusion will be called as the Cotard syndrome. When it will be called the Cotard syndrome, remember when it will be called as Cotard syndrome, when there will be what some other symptoms will also be associated. No, some other symptoms will also be associated. Right now, like that is called the Cotard syndrome. Okay, this one point is clear to everyone. But remember here, suppose if examiner would have asked you only one answer key, what is the diagnosis? I could have marked number one answer could have been the Cotard syndrome because patient is also having milder symptoms of depression also. So Cotard. But here, here like examiner is mentioning a delusion. Which type of delusion? It 100% nihilistic or negation. This much point is clear. I would say this is 100%. This was very easy question for you people, right? Very easy question. Next, what could be the likely diagnosis for a 16-year-old girl who experiences strong food cravings and engages in excessive eating followed by self-induced vomiting? I would say this is easiest question for you people. 100% easy question for you people now. And easiest question for you people. Can you answer me what is the diagnosis here? More binging, more vomiting. I say no, full plate biryani, she is having full plate. But after 4 to 5 hours, she was having regret. Oh my God, I have eaten a lot. Then there will be more vomiting also, bulimia and nervosa also. Next. A patient has stopped alcohol consumption for 3 days and presents with irritation, disorientation, paranoid delusion, agitation, visual hallucination, altered sensorium. What is the answer here? I have taught you to say, remember, I have taught you rule of 6, more than 6 hours, more than 12 hours, more than 18 hours, and I see more than 24, more than 48 hours. Means when a person has stopped taking alcohol for more than 2 to 3 days. Okay, no, then there will be what? delirium tremens. Delirium tremens, where patient can have symptoms of what? Severe mental confusion, visual hallucination, right? No, auditory hallucination, tactile hallucination. Patient can be irritated. Okay, can you answer me? Like, if you do not treat delirium tremens on time, how much will be the mortality rate? Mortality rate will be 20%. Mortality rate will be 20%. Okay, fine. After that, how to treat delirium tremens, I have taught you. Yes, injection of benzodiazepine and vitamin B1. Okay, so injection of lorazepam we are using. Can you answer me? Why do you add vitamin B1? Yes, to prevent one more emergency that is called as Wernicke's encephalopathy. Okay, next question now. What is the probable diagnosis for a woman who is 4 days postpartum and experiencing tearfulness, mood swings, occasional insomnia? I have taught you postpartum blues, postpartum psychosis, postpartum depression. I gave the example within the first week only postpartum blues can be seen. Postpartum depression can be seen within 3 months also. Okay, no? And psychosis anytime within 2 to 3 weeks. Postpartum blues, I asked you to memorize in this manner. Blues within 3 days, psychosis, 3 weeks, depression within 3 months. Okay, so here milder symptoms you can see, mild symptoms are only here. No, this is a case of postpartum blues only. Postpartum blues only. Yes, no. Postpartum depression, can you answer me? What is the drug of choice for postpartum depression? Lady SSRI, sertraline. Next question now. A 32-year-old man with a known diagnosis of antisocial personality disorder is admitted to the medical world for management of injuries sustained in a fight. He is demanding, manipulates the nursing staff for extra medication, verbally abusive. Right? The treating team is concerned about his destructive behavior. What is the single most important and immediate management strategy for this patient in the inpatient medical setting? See here, I'm sure, see here, it is mentioned that this is a case of antisocial personality. But being a doctor in hospital, being a person of the leader, how you are going to help how you are going to handle the situation here? Okay, no. First of all, remember here, yes, you have to confront the patient firmly about his behavior. Sometimes, yes, we can shout on the patient also. Right now, so this is for the betterment of that patient, and for the other patient also. Okay, no, fine. So we have to set consistent, non-negotiable limits also. Sometimes, yes, we have to do like this. Okay, we have to do like this also. Right now, so remember about the single most important and the immediate management. We have to confront the patient firmly. Right? B is better answer here.